Welcome to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, the Executive Director of Speaking of Women's Health. And I am back in the Sunflower House. And on this new episode, I am interviewing ophthalmologist extraordinaire and eye surgeon, Dr. Scott Wagenberg. And we are going to be talking all things cataract. I think pretty much almost everyone I personally know sees him. I don't know how he sees so many patients. He is one busy guy. And Dr. Scott Wagenberg is part of the Cole Eye Institute at Hillcrest Hospital at Cleveland Clinic. And he was in private practice from 2000 to 2010, and then joined our Cole Eye Institute in 2010. Dr. Wagenberg earned his medical degree at the University of Michigan, so don't be upset for all you OSU fans. He did an ophthalmology residency right here in Cleveland at Case Western Reserve University, and then he completed a fellowship in corneal and refractive surgery at the Corneal Consultants of Indianapolis, and he has been board certified in ophthalmology for 23 years. Dr. Wagenberg specializes in diseases and surgery of the cornea, and he is at the leading edge of corneal transplantation, including endothelial keratoplasty, known as DMAC and DSAC, deep anterior lamellar keratoplasty, DALK, and penetrating keratoplasty. He has helped design a keratome for the purpose of preparing the corneal tissue for this endothelial keratoplasty. And he's lectured at regional, national, and international eye conferences. He's also performed live surgery at an international corneal conference. In addition to his interest in corneal transplantation, he has interest in the ocular surface reconstruction, including the use of amniotic membrane for the repair of the corneal surface. So there's his link to women's health. In addition to his interest in corneal diseases and surgery, he also practices a comprehensive ophthalmology practice, which includes treatments of cataracts, which most people would get if they live long enough, glaucoma, contact lens fitting, dry eyes. If you haven't heard the previous podcast I did on dry eyes, which affects so many women, please go back and listen to that in season 1, as well as inflammation of the eye. He is a member of the American Academy of Ophthalmology and the Corneal Society, and no surprise, he's listed in Best Doctors in America. Welcome, Dr. Wagenberg.
Hello, thank you for having me.
Well, thanks so much for joining us on this podcast to talk all things cataract. I mean, the eye is so fascinating. People say it's the window to the soul. What do you think?
Yeah, that's what they say. You can tell some diseases such as diabetes and high blood pressure by looking into the eye. Plus, as we get older, it's probably the most important sense we have. A lot of times we can't do much physical stuff, so our eyes are what we use to have fun.
Yes, certainly our special senses are so important, and they seem to take a beating. I mean, I think protecting the eyes from ultraviolet light from years of, I love to be outside golfing. People like to swim, the reflective, we got the solar eclipse. And certainly with age, we do have changes in lots of body tissues, specifically the lens, which can develop cataracts. And not all of us are going to be famous French painters like Monet, who did those wonderful paintings based on his cataracts, I presume. So do you want to tell our audience what is a cataract?
Sure. So first, I'm just going to give a little general explanation of the structures of the eye. If you think of the eye like a camera, the front of the eye, it's called the cornea. It's like a window, like the window on a house. Then you'll have the lens. That's where the cataract will be. Then you'll have the retina, which is like the film in a camera. And then the nerve, which would be like a cord from the camera to a computer. So the problem with the cataract is the lens. When you're born, it's clear, and as you mature, it starts to cloud over. If you think of it like a grape with a seed, it's actually the seed that is the cataract. So that's the part that gets all clouded. And that's the part that we will fix when we do cataract surgery.
And is it true that you can have more than one type of cataract in the eye? Like I saw a patient in the office yesterday, and she said that she had three types of cataracts and it didn't really bother her that much. But her ophthalmologist said that they couldn't even see into the back of her retina. So how the heck could she see out?
Right. So there are different types. There's a nuclear sclerotic. So that's cataract we think of as we get more mature. There's a posterior subcapsular cataract. Those are usually what people get if they're on steroids or if they have diabetes or if they had a traumatic injury to the eye. And then there's a cortical cataract, which is like little spokes on a bicycle wheel. And that also usually comes with age. All the cataracts, all the different types are all treated the same way, though. So a lot of people have more than one type, and it doesn't make the surgery any more difficult or anything else worse.
Oh, well, that's certainly good to know. But does that influence, like if somebody is really young? Like I've had some patients who've had cataract surgery like in their 40s, which it seems like most people are generally like in their 70s.
Correct. So most people who have it when they're younger, they've either had diabetes or they've had an injury or they've been on steroids. Sometimes there's a familial component to it. And so some people just get cataracts at a younger age. And then if you've been sick with diabetes or certain types of cancer, that can influence your cataracts as well.
Okay, interesting. Yes, my husband, who I've talked about on this podcast, how he was complaining like he didn't want to make an appointment because he was just seen 3 months ago. And I'm like, if you've got a new symptom, you have to go in, especially if it's something that has to be examined. His parents had cataracts in their early 50s with nothing else medical going on. So I really thought he was going to have surgery even sooner than he did. So that's interesting about the genetic component. Is it more likely to be in lighter eyed people, like blue eyed people, as opposed to darker eyed people, or people who have more pigment just generally in their skin?
There's some belief that macular degeneration is more likely to be in people with fair skin or fair eyes, but the cataracts can be in anybody. It doesn't really matter how pigmented you are.
Oh, that's interesting. And so what are some of the classic or more typical symptoms or even atypical symptoms that somebody might have?
So the classic symptom would be clouding of the vision, especially glare or halos when driving at night. Some other symptoms, you can get double vision in just one eye, trouble reading, needing a lot more light to read. One that's a little atypical is you can have changes in your glasses. All of a sudden your glasses change like every 3 months, and usually you'll become more and more nearsighted. And so that's one symptom. A funny symptom is that some people who are farsighted, when they start getting their cataracts, they can become a little bit more nearsighted, and they get what's called second sight, and all of a sudden they see better without their glasses than they did with their glasses.
Oh, interesting, interesting. So for our listeners that aren't ophthalmologists, if you're nearsighted with age, you don't have as much trouble like reading. You don't need to grab for those reading glasses or extend your arm out. Is that right?
Correct. The more nearsighted you are, the less trouble you'll have with reading, to a point.
To a point.
Yeah, if you're super nearsighted, you won't see anything. You'll have to hold it right up by your face.
Oh, wow. Wow. And then the farsighted people are better at seeing things at a distance, like say in driving?
Distance. Correct. But still, if you're too farsighted, then you'll need glasses as well.
And then is optimal vision as you're over age 40 or 50 like monovision? And is there people in their 40s who don't have any eye problems or cataracts, but maybe they're nearsighted? Should they start to experiment with that to train the brain?
No, I don't think there's a way to train the brain. About 80% of people, 80, 90% can handle monovision. I don't know if you'd say it's optimal vision. Some people like it and some people don't. It depends on what your lifestyle is. So maybe a truck driver would rather have a lot better distance vision. And so having both eyes see good for distance is probably the way to go. But then people who do work, the monovision would be a good option for them.
Okay.
A lot of times you can try contact lenses to try monovision out to see what you think about it before you have surgery. But I think we'll talk about that in a minute.
And how do you go about diagnosing cataracts? And what are some of the specific tests or people that should be asking their physician, their ophthalmologist, or even optometrist or whoever they're getting their care from?
Really, the only way to diagnose it is with an eye exam. So we look into your eye with the slit lamp, that machine that you see when you go for an eye exam. And you'll see a clouding of the lens inside the eye, and that will determine if you have a cataract. Whether or not to do the cataract is really up to the patient. It all depends on your symptoms. Some people will have terrible cataracts, but they're not bothered by their vision, and I tell them to wait on getting the cataract surgery. Some people won't have very many symptoms at all, but it bothers them, again, like people who need to drive at night, and they'll get their cataracts done at an earlier time. So it's really person dependent. There's very few times that I will look at somebody and tell them that they have to have their cataract out, and that will only be if their cataract is causing another problem like glaucoma, or they have diabetes in the back of the eye and they cannot be seen in the back of the eye, so they need to get the cataract out for a better view.
Oh, interesting. So there can be situations where the patient's not complaining of seeing, but the cataract is that dense that it makes it difficult for the physician to evaluate all the vasculature on the back of the retina?
Yeah, that's correct.
Wow.
It's interesting. You'll see some people who come in and they can't see anything out of the eye and they don't complain about it because their other eyes see as well. And if they want to wait, they can wait. The nice thing about a cataract, it's like a car window. No matter if you get a little scratch on your window or you shadow your car window, once you fix it, you see just as well, and you never knew how bad it was. It's the same way with a cataract. Once you fix the cataract, no matter how bad it was, you'll see just as well as if you did it, and you'll never know how bad it was. So there's no rush to getting the cataracts out. It's not like a bad heart or something like that.
Oh, that's very interesting to know. And if a person has a cataract in one eye, or do they generally, it seems like most of the patients I see in the clinic, they have them done like a month apart. Like generally speaking, whatever the aging process is affects both of the eyes, assuming it's not trauma. Or do you see a lot of just unilateral disease?
I see a lot of unilateral disease, to be honest. Some people will get one eye done and then they'll be happy with their vision. They won't want to get the other eye done. Some people get one eye done and we didn't think the cataract was that bad in the other eye, but they'll notice a difference in color. Because when you have a cataract, things will seem a little bit more yellow or washed out. And even though the vision in the other eye is pretty good, they'll want to get the cataract out to make the color the same in both eyes.
Interesting. I was just talking to a good friend and big supporter of Speaking of Women's Health recently, and she said that she had hers done, and like she opened her eyes and immediately it was like the world was in Technicolor. So are there people that just don't see that contrast in color over time?
Yeah, because the cataracts are slow growing, they happen over, years to decades. You're losing your vision gradually and gradually, and you really don't really realize that you're losing the vision. And so after you get that cataract out, all of a sudden it's a big improvement in your vision. Then you realize the difference. So if you have one eye done and you have a bad cataract in both, all of a sudden you realize that, boy, things are a lot brighter. There's a lot more detail, and you didn't realize what you were missing out on.
Wow. Wow. Well, that's exciting. And with like children, if they have a lazy eye, even though the eyeball is perfectly fine, they can develop blindness at the brain level.
Right.
Correct? So does that ever happen with adults? Like once you develop that vision, like if you had such a bad cataract and fixed it, is there ever any suppression from the brain or not?
Not really. What can happen, usually if you develop your vision by the age of 8, you're going to keep that vision no matter how bad your cataract is. What can happen if you have a prolonged or chronic cataract and you can't see out of that eye is the eye can start to wander a bit, and that may not come back into step, and you might have to have a second surgery to fix the alignment of your eyes.
Oh, like involve something with the muscles.
With
Is
the
that
muscles,
right?
correct.
Okay. And what can the average person do to protect their eyes to reduce the risk of cataracts?
So I would say the main things are you want to avoid smoking, avoid excessive sunlight, wear your sunglasses. Heavy drinking is bad for cataracts. The other thing is eating a balanced diet has been shown to help a little bit in slowing down the development of cataracts. Some studies have shown that like Centrum Silver can cut down the risk of cataract a little bit or slow the growth. But the main ones would be no smoking and sunglasses.
And do the sunglasses have to be polarized? Do we have to worry about the blue light that we get from the computer screens that most of us are on all day?
I think the risk of the blue light is overblown. That being said, when you change the lens in the eye with the cataract surgery, it does have a blue light blocker in it. The main thing, though, is that you need the glasses to have UV protection. The polarized is good if you're getting a lot of glare. So you want the polarized glasses to cut down on the glare, but it's not necessary. Just the UV protection is the main necessity.
And do the lenses that you implant, do they have UV light protection or just the blue light protection?
Correct. They have UV light protection and blue light protection. There are several different types of lenses. Do you want me to discuss the different lenses?
Oh, sure. Absolutely. You've been listening to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, the executive director of our nonprofit, Speaking of Women's Health. And I am speaking with ophthalmologist Dr. Scott Wagenberg. And he's talking about all things cataract, and we're moving into what the treatment options are, different types of lenses.
So if you decide to have cataract surgery, what will happen is you'll come in and you'll get these measurements performed on your eye. Well, they'll measure the length of the eye and the curvature of their eye, and that'll be put into a calculation to determine what lens to put in the eye. After determining what lens can be put in the eye, there's several options. The most common option is called a monofocal lens, which allows you to see either distance or up close. Some people will have one eye made for distance and one eye made for up close. That's the monovision we discussed earlier. Mm-hmm. A second option, if you have astigmatism, which means your eye is shaped like a football instead of a baseball, is there's a special lens called the toric lens, which will correct that astigmatism so that you can see better. The problem with that lens is it's not covered by your insurance, so you end up having to pay an extra fee for that lens. The third option is there's something called a multifocal lens, which allows you to see distance and up close, but neither of them as great as you would with a monofocal lens. The other problem with these multifocal lenses is that they split the light, and there's about 10% of people will complain of glare or halos, and about 1% of the people will actually have to get the lenses removed and changed for a monofocal lens. That lens also comes with a big price tag, so it's something to think about. When I did my partner's surgeries, they could have gotten the multifocal lenses with no cost, but they opted to get the monofocal lenses because they didn't want to have the glare problems.
Interesting.
So that's what I would recommend is the monofocal lenses.
For most people.
Or the toric lenses, depending on the shape of your eye.
Okay. So if someone has tried multifocal contact lenses, like I personally tried them, and I just felt like I was on LSD or something. It was just such a strange experience. And it felt like my near vision wasn't as good as it was without contact lenses, and my far vision, I had been used to 20/10 vision with like overcorrection for several years.
Correct. So somebody like you would not like the multifocal lenses. Somebody with a type A personality wouldn't like a multifocal lens. Somebody who's going to check their eye by going back and forth all the time wouldn't like a multifocal lens. Somebody who comes in and their vision is actually pretty bad and they didn't notice it was very bad, they might like a multifocal lens because they're not as as disciplined in their vision. Yeah.
Interesting. And obviously people's occupation makes a difference too. Yeah, that's interesting. You operating on your eye surgery partners, because of course they need good eye vision to do eye surgery.
Right. Yeah. So I think the technology is getting better for multifocal lenses, but if it was my eye, I would not have the multifocal lens at this time.
At this point, and we're of course in season 2 in 2024. I mean, it's interesting that there's so much technological advances. Like for instance, with joint replacements, I've just seen that field progress so rapidly. People used to have prolonged rehab, major blood loss, having to donate months in advance. And now sometimes people go home the same day. It just seems like just the procedure and all the associated effects of it seem to be better. I have a patient who comes in to visit me from another state, and she's a nurse that works in a private practice ophthalmology practice. And she's like, oh, come see us, even though you'll pay out of pocket. Don't wait till you have problems with your eyes. Just preventatively get your lens placed. And I thought that's really surprising because, anytime you do an operation, there's always a risk and it's not going to be foolproof. Do you ever
Correct.
see anyone that's so dependent on their vision that they preemptively do something like that?
I have. I usually, if somebody comes in and wants to have cataract surgery and they don't have cataracts or the cataracts are real mild, I'll actually refuse to do it. And, I'll give them some names of some other people who might do it. But typically, I like to treat people with eye diseases. So I'll wait until they have a problem with their cataracts before I'll do surgery.
Yeah, in general, that just seems to go along with our principle of do no harm. Is it that people have such bad vision that they want a different lens than their own natural lens? But you operate on the cornea, right? If you're trying to change vision, like LASIK eye surgery.
Yeah, I do not do LASIK eye surgery either. I'll do like corneal transplants and whatnot. But some people will try to get it, that's called a clear lens extraction. So instead of doing LASIK, because they're not a good candidate for LASIK, they'll get their lens removed and then get a new lens placed into their eye.
And that helps their vision?
Yes.
Okay. So is surgery generally the only option in terms of dealing with a cataract, a diseased lens?
Yeah, surgery is correct, the only option. You can try to get glasses to see if that'll help, but surgery is the only option.
Uh-huh. Uh-huh. And so what does the surgery involve?
Let me interrupt you one sec. I got music going in my background. Do you have music going on yours, Holly?
No. No, I'm not hearing any music. I wonder if you're
I don't know what that is.
picking something up on your on your earbuds. Like, is your phone on? Sometimes if I touch my earbud, my Apple
Yeah, I
iTunes
think
music
that's what
comes
happened
on.
is I touched my earbud and something came on. It's my daughter's earbuds and her music came on. I'm sorry for that.
Oh, no, that's fine. And so you're the father of 4 children, is that right?
That's correct. Yeah, 3 boys and a girl.
3 boys and a girl. Was the girl the last one?
The girl's the last one, yeah.
Yeah, I had 3 boys, but I stopped. I couldn't try 4, even though my husband really wanted a girl. But we have 2 granddaughters, so that's exciting.
So
And
yeah,
is it?
now you're made up for it.
Yeah, so it's like it's just been great. But so isn't your daughter like internationally known?
No, and she's not internationally known. She likes to do weightlifting. And at 13, she set the national record for squatting.
Well, so
But
she's nationally known. That's great.
it was at a local tournament, so she doesn't get credit for the national record. So the Ohio State record is better than the national record.
Well, that's cool. So that you make up for going to the University of Michigan then by having a
That's right.
daughter who set an Ohio State record then.
And my youngest son will be going to Ohio State next year, so I make up for it that way too.
Oh, well, that is great. That is great. So are any of your children going to follow in your footsteps and be physicians?
I think my daughter wants to be a dermatologist, and that's the only one.
Oh, that's a smart choice. That's a smart choice. I remember when I got my board scores in medical school, everybody exclaimed, "Oh, you can get into a dermatology residency." And I'm like, "What? No, I'm too smart for that. I want to be an internist." Oh boy.
When
Anyway,
I
I've
went to
had it.
school, you had to do a year of internship before you could apply for dermatology. Was that the same with you?
No, actually, you still had to do a year of a rotating internship, but you still matched into dermatology.
Yeah,
So
see, you didn't do that for a year after, so you're taking a
yeah, so
chance.
yeah, I know. Yeah, I didn't. I didn't go that route. I just came to the Cleveland Clinic to do internal medicine because I thought I was going to be a cardiologist and I didn't want to move my husband twice. But then I kind of designed my own interdisciplinary field. So it's been a great career. But one of my friend's daughter just decided to go into dermatology for medical school, and she was so heartbroken. And I'm like, no, people should follow their passion, and that's a great field. So good for your daughter. So getting back to the whole cataract surgery discussion, how do you prepare for cataract surgery, the patient?
So we will bring them in and do those measurements as we discussed, and then I'll go over the surgery with them. Then they'll come in on the day of surgery. They'll be dilated, given dilated eye drops like they get in the office. And then we bring them back into the surgery. They'll get an IV, and usually we'll give them something to relax by IV, but you'll be awake for surgery. Now, some people don't want any medication for relaxation, and some people we actually will put to sleep like when you're getting a colonoscopy. The
Mm.
surgery itself typically takes about 5 to 10 minutes, and then we bring you back out. They give you a cracker and some coffee, and then you're on your way. So I would
I was,
say the whole day takes about 2 hours because about an hour and a half of paperwork and getting dilated, and about 10 minutes of surgery and 20 minutes to recover.
wow, that is so nice and fast and slick. I was like shocked when I took my husband in. I didn't even finish answering like one or two work emails by the time they were they were wheeling him back. Um, so that is very nice. And what is it exactly that you're doing? Can the patient who's awake actually see what you're doing?
Yeah, so they will actually see it will be like a kaleidoscope for them. Some people say it's like they're on acid, um, but they don't actually see the instruments doing anything. I think what happens is the pressure in the eye, as we are chopping up the lens and removing it from the eye, causes these visual patterns on the eye that they can see, and it's supposedly a pretty cool view.
Interesting. And what's the general recovery? Obviously, everybody's individual. I understand that. What's the general recovery after cataract surgery and the precautions that people need to take?
So it really depends on the age of the patient and how bad their cataract was originally. Younger patients who had a mild cataract, they can see better usually the next day. Some older patients might take a day to a week in order to see better. What happens after surgery is you get a little swelling of the cornea, the front of the eye. And so it takes a couple days sometimes for that swelling to go down, and so you can see as good as you want to.
And my husband ended up getting that unusual symptom of negative photopsia. Is that based on the size of the eye or the lens or just the placement, or is it just something that happens
Yeah,
and the brain needs to suppress?
what it is negative dysphotopsia is you'll see something on the side of your vision that isn't actually there. And for some reason, it occurs more in the left eye than the right eye. We're not sure why. And we're actually not sure why you see it. Usually the brain will suppress it, and it can take anywhere from a week to 6 months for the brain to suppress it. There
Hmm.
may be something to do with the lens material, and some people are affected by lens materials different than others. So if a patient has it and it lasts longer than 6 months, we'll actually remove the lens and replace it with a different lens of different material to see if that will get rid of the dysphotopsia, and it usually does.
And so, like, what are the lenses made out of?
Most lenses are made out of acrylic, um, but there's different kinds of acrylic. There's hydrophilic and hydrophobic, which means they like water or they don't like water.
Hmm.
It's a little bit technical, but most of the lenses would be acrylic lenses.
And is there a reason why you would pick one over the other? Like if someone has glaucoma or just the size of their eye or their age? I would imagine like children would be different than adults, or do you pretty much have your grown eyeball size by a certain age?
Yeah, usually the children's lenses are the same as the adults' lenses. If you think of the cataract like a grape with a seed, what we do is we remove the seed, but we keep the skin. One of the complications of surgery, probably the biggest complication, is that skin can break. And if that skin breaks, we can no longer put the artificial lens in the old skin, and we have to put it in front of the old skin. And that would be the main reason for using a second kind of lens.
Oh, interesting, interesting. And then once you get your new lens, do you ever down the road have to get another one? Like I know with like joint replacements, sometimes people would wear them out, or it would be such a big deal to have another implant, of another device. Does that ever happen that
What can
you
happen
have?
is you can get what's called a secondary cataract or posterior capsular opacity. What it is there's a little clouding of the membrane that we push that lens on top of. And then
Hmm.
if that were to happen in the office, we do a simple laser that you can actually drive home after to poke a little hole in that membrane so that you can see clearly. The lens itself, though, usually will last for the rest of your life.
And is there any problem with like dislocation if someone's in contact sports, or if you ever see like a professional athlete, or do they have to avoid certain things or head trauma? Is there any chance of that, or?
I have seen some lens dislocations, usually in older patients. Sometimes they fall and hit like a table or whatnot. Most athletes probably are too young to have a cataract, so we don't have to worry about it in them as much. But
Uh-huh.
older patients sometimes can have it. And sometimes what can happen is there's little wires that hold the lens into place. They're called zonules. And with age, those wires start to break and the lens can start to dislocate. If that were to happen, we either have to remove the lens and sew a new lens in, or sometimes we can just sew the lens to the white part of the eye.
Oh, interesting. How often does that occur?
It's pretty rare. I
Uh-huh.
would say less than 0.1% of the time.
Ah, okay. And since these lenses have the blue light and the ultraviolet light, is it less important that the person wear their polarized sunglasses when they're out in bright light to help protect their retina, from macular degeneration or?
I still recommend that people wear their sunglasses. I think it gives you added ultraviolet protection. That also protects your eyes in case you're walking and maybe a rock were to fly out of a lawnmower or something like that. So I always recommend people still wear their sunglasses. I'm not sure how great the UV protection is in these artificial lenses. So I think just an
Okay.
added layer of protection, especially if somebody is prone to getting macular degeneration or already has macular degeneration, I'd
Hmm.
recommend they wear it.
And is there any association with the dreaded macular degeneration with cataracts or glaucoma? Or are they all just separate events, somewhat age
They're all
related?
separate events. Now, sometimes cataract surgery can cause glaucoma, but usually that would be a special circumstance where we use eye drops after surgery, and the drops cause the eye pressure to go up. Those would be the steroid eye drops.
Okay, okay. And that's usually part of your regimen, steroid eye drops and
Correct. After
antibiotic use.
surgery, you'll use drops for a month, steroid eye drops 4 times a day for a week, then 3 times a day for a week, then twice a day for a week, then once a day for a week. And you'll also use an antibiotic drop 4 times a day for 5 days.
Excellent. And when you were mentioning that good nutrition, obviously makes sense. It's anti-aging. We've had several podcasts, on the themes of anti-aging, and nutrition and superfoods. Is it the same substances that a lot of the eye, you see a lot of eye vitamins over the counter, like Ocuvite or things with lutein. Is it the same substances that are good for the retina that are good for the eye lens?
Correct. There's been one study and it didn't show any difference in the super eye vitamins like the Ocuvite and Centrum Silver as far as slowing down the progression of cataracts. Basically, it's fruits, vegetables, essential fatty acids. Those are
So,
the main things.
so like the omega-3s, I see a lot of patients come to see me and they said that their eye doctor told them to take omega-3 fatty acids or eat more fish for their dry eyes or their eye issues.
Right. So there was a belief for a long time that the essential fatty acids, the omega fatty acids, were anti-inflammatory, and there were enough anti-inflammatory that they would help with dry eyes and increase the tear production. I don't know if that is held true with the current studies, but those essential fatty acids are definitely better for helping with our heart and health. So I think they help with the cataracts as well.
Oh, that's very interesting. Um, So if one of our listeners wanted to make an appointment to see you for an eye exam, cataract, or corneal evaluation, how would they go about doing that?
So you would call the Cleveland Clinic. Our office is 440-461-4733, and they can set up an appointment with me or, any of my colleagues.
That's terrific. And any final parting words?
Just if you feel like your vision is not bad and somebody tells you you have a cataract, I would think twice about having cataract surgery. Cataract surgery is only needed when you feel like it's needed. Let somebody talk you into it if you don't feel like you need it, unless they mention that you're starting to develop glaucoma.
And one of the podcasts that I did last season was with an expert on Medicare and picking your secondary Medicare insurance. And I know that's always the bane of really a lot of practicing physicians, even with commercial insurance or Medicare or whatever, is just like what is covered. And is it true that the cataracts need to be 4+ or pretty severe, regardless of how the patient feels, for certain insurances to cover?
Yes, so there has to be, if your cataracts, if you see 20/50 or worse, they're covered automatically. If you can glare test somebody and we shine a light at their eyes and check them, and if they're less than 20/50, worse than 20/50, they'll be covered as well.
Okay. Okay. And then if someone doesn't have coverage, but they just want to have it done, I presume just like with any surgical procedure or medical procedure, there's cash options, cash pay options.
Right, you can pay out of pocket. Those are the clear lens extractions we talked about earlier. And there are some surgeons who do that so that you can get rid of your glasses.
Oh, okay. Great. Great. Well, thank you so much, Dr. Wagenberg, for joining us on this podcast. And thanks to our listeners for tuning in to another episode of Speaking of Women's Health. And we're grateful for your support. And we hope that you'll support our podcast. Please share it with others. You can also give us a 5-star rating. If you don't already subscribe to our podcast, you can just by hitting follow or subscribe for free to catch all the latest from Speaking of Women's Health. Go wherever you listen to podcasts, and you can go on our website, speakingofwomenshealth.com, and donate, if you would, to our nonprofit. And if there's anything you want to hear us talk about, go to the Contact Us form and ask us the question, and maybe we'll answer your question or have a podcast on that. Thanks again for listening to us, and we'll see you next time in the Sunflower House.